Then I will pass the question to Dr. Kantarjan.
Can you repeat the question because I just joined in?
So in translocation 8 to 21, is there a standard level of MRD detection? Is there a standard level of MRD detection in acute myeloid leukemia?
So for the 821 translocation, we would like the PCR level to be 0 by the end of therapy. If not, we add either azacitidine, Mylotarg, venetoclax for another 6 to 12 months or consider a transplant. That's not the case for inversion 16. We've seen some people with inversion 16 that have very low levels, less than 0.01% beyond the second and third year, and they have never relapsed. So it's a bit different between translocation 821 and inversion 16.
Okay, thank you. I would ask the audience to post any questions if they have any questions. Another question, Dr. Kantarjan, can the treatment intensity reduced in patients who achieve MRD negativity after induction?
So we do not know that, but the reality is when we use the FLAG-IDA venetoclax or the CLIA venetoclax, those treatments are quite intensive. So beyond the second, third course, most of the patients start having myelosuppression, but we try to transit them to transplant always. If not, and if they cannot tolerate additional intensive chemotherapy, then we go to the maintenance, which is with either oral decitabine venetoclax for 2 years or azacitidine venetoclax for 2 years. So these things are changing very quickly now, and we're trying to catch up with this. But to answer the question, in particular, if you're using 3+7 and the patient has become MRD negative, this is a good time to do the transplantation. Otherwise, complete the 4 cycles of high-dose Ara-C and consider maintenance with AZA or decitabine venetoclax-based therapy.
Thank you. Another question I see here from the audience: do you prefer you mentioned reducing venetoclax days. Do you prefer reducing the dose instead of days in patients with AML?
No, actually, for the low intensity, if you're using venetoclax with azacitidine, you have to do the induction for 21 days. The maintenance will be between 7 and 14 days, depending on the degree of myelosuppression. If you're using it with intensive chemotherapy, then it's only 7 days with the induction and consolidation. But we do not reduce the dose beyond 50 milligrams with cosaconazole because we have never done those studies. So the standard dose is 400 milligrams without azoles and then reduced with the azoles. But we do not reduce it further to avoid in order to shorten the number of days. There's no experience with that.
Thank you. Thank you. I see here a question. How do you approach a young fit patients with a diagnosis of FLT3 negative NPM1 positive AML after 3+7 and first consolidation with HiDAC who has detectable NPM1 and who also has the full mass sibling donor? Will you go directly to a transplant or you continue to monitor them closely?
So you have to go to a transplant. On average, every time we have done the transplant versus consolidation and maintenance so far, the transplant beats the intensive chemotherapy by about 5 to 10%. So you have to go to the transplant, but because this patient is NPM1 mutated, you could consider pre-transplant AZA venetoclax to make them negative, or if you do the transplant, then consider post-transplant maintenance therapy with azacitidine venetoclax.
Thank you. Thank you. I'll see here another questions. Can patients with the prolonged cytopenia challenge MRD interpretation?
So the question here is, historically, people who have prolonged cytopenia, this was an indication for relapse, but this is not the case anymore. Now we see patients with prolonged cytopenia who are MRD negative and they are not relapsing. And that's because we're using different, more intensive therapies. We're adding the venetoclax. So if you observe prolonged cytopenia without MRD positivity, I would not worry. But this is where the possibility of the allogeneic transplantation would be of value.
Thank you. Thank you. A question to Dr. Kamrokji. Is there a dose escalation for venetoclax, and do you see tumor lysis syndrome?
No, in MDS, as I mentioned, the induction phase of it is 14 days. The package insert does still say, obviously, escalation. Now, the use of venetoclax in MDS is still investigational. We use it sometimes. In our practice, we don't dose escalate. We start with the dose from the beginning, as Dr. Kantarjian has detailed in his talks, almost following that. The only difference in MDS is we do only 2 weeks with the first round. And as Dr. Kantarjian mentioned, in the subsequent cycles, you really have to cut down the dose, and if you add prophylactic antibiotics. So in our practice, we don't dose escalate. We do observe tumor lysis at the beginning, but we've not seen tumor lysis in MDS, and we do only 2 weeks in the induction.
So Dr. Shaybani, may I add a little bit, because that's a very important point. If you have a patient with AML with a high white cell count, I would cytoreduce the counts to 2,000 or less before starting the venetoclax. When we have added the venetoclax on day 1, we have seen tumor lysis and renal failure. We had several cases of renal failure, so now we delay starting the venetoclax until we have reduced the white cell count to less than 2,000. And you can do this either with hydroxyurea or with 1 dose of Ara-C. But that's a very important point in terms of the toxicity. And in those patients, we do venetoclax 20 on day 1, 50 on day 2, and then 50 on day 3 with posaconazole. And we watch for tumor lysis and renal failure, because it does happen with a high tumor bulk.
Thank you. Dr. Kantarjian, another question for you. Would you consider auto versus chemotherapy as consolidation in translocation 8-21?
So that's an interesting question, because as you know, the autologous transplant is almost abandoned in the United States. It is very common practice in Europe. In Europe, what they do is they do the 3+7, 1 dose of high-dose Ara-C, and then either allogeneic or auto-transplantation. Now, since we started measuring MRD better, so the historical data show that the autologous transplant may be equivalent to intensive chemotherapy for courses of high dose, but it is inferior to the allogeneic transplantation. But now that we can measure MRD to levels below 10 to the -4, one could think, well, can we use the autologous transplant now as an intensification in patients where we know they are MRD negative instead of the allogeneic transplant? And that's a question that remains investigational. Nobody has done it. The particular question of autologous transplant in core binding factor leukemias is relevant, because as the person who asked the question realized, there is data that in this setting, autologous transplant can be very effective in these patients if you can take the stem cells from the patients and prove that they are MRD negative.
Thank you. And is there any rule for venetoclax in advanced phase myeloproliferative disease?
I'm not sure that that's the case. Actually, Dr. Verstovsek always says that in the myeloproliferative disorders, it's a unique situation where there's no BCL2 overexpression, and venetoclax may not help, and it may even harm. Now, he makes the point that navitoclax, which is a BCL2 BCXL inhibitor, could work in the setting of the myeloproliferative neoplasms, but that's not proven yet. So although venetoclax is helpful in CLL, in AML, in MDS, maybe in ALL, I think it is not a drug that we are ready to look at in myeloproliferative neoplasms. It may not help, and it may harm a little bit.
Thank you. Another question: will you give further chemo if pre-transplant NPM1 came positive?
I think if you have a patient who is NPM1 positive by next generation sequencing or by the PCR, if you go directly to the transplant, they may do slightly worse. So you have to either consider pre-transplant additional intensive chemotherapy or azacitidine venetoclax, or consider a post-transplant maintenance.
Thank you. What about post-transplant AML relapse? Any benefit of venetoclax?
I think this is where azacitidine venetoclax has worked pretty well. So if you have a patient who relapses post-transplantation, by the way, if you have a patient who's transplanted, we're always starting to consider some maintenance after the transplantation. So if they are FLT3 positive, you add a FLT3 inhibitor, gilteritinib. If they are if you're not guided by mutations, then you may consider azacitidine venetoclax. Now, if they relapse post-transplantation, I think without any guiding mutations, decitabine 10 days venetoclax would be useful. If not, FLAG-IDA venetoclax if they are younger patients.
Thank you. Thank you so much for Dr. Kantarjian, Dr. Wood, and Dr. Kamrookji. By this, we conclude our session. I believe next will be the virtual meeting. Thank you all.